Dr. Frederick has done a lot of work and it's made my work easier. I'm going to talk about medical oncology part, not radiation, not cost, but I want to tell you about the medical oncology part in choosing wisely, which test to do, which one not to put your money on, how to save patient cost, how to avoid unnecessary tests that cause actually more harm than good. And I hope at the end of this session we'll be able to have a discussion on some of the tests. My name is Omar. I'm from Kenya, and I work at a Nairobi Cancer Center and a rural cancer center which I established with other colleagues. And I would like to share at the end of my talk, I'll tell you my experience on choosing wisely in a real world setting. Okay? So choosing wisely has been defined several times, and most of the previous speakers have talked about this. It's basically, in summary, choosing the correct test for the correct patient, cost effective, it does more good than harm, and it's easily available. Okay? Those are the basic tenets of choosing wisely. And specifically in low and middle income countries, even more poignant and more important, because this is where we have the list of the resources, so we better use what we have in a better way, okay? So this is just the list of different types of, Choosing Wisely campaign that led to publications. This is Choosing Wisely India, this is Choosing Wisely Philippines by Dr. Frederick and his team. There's Choosing Wisely in Brazil. So this is really an international campaign. Everyone trying to really work for their patient. Next, I would like to see patients choosing wisely, paper from Cambodia, I hope, very soon. It's a challenge to the local oncologist. Speaking of low and middle income country, which I will say Cambodia is probably in that bracket, me and my other colleagues had, summarized a paper talking about the Lancet, which was published in the Lancet, talking about, the state of low and middle income countries, the cancer care landscape. And as you'll see, there are 10 low and middle income countries, recommendations. And Africa, for example, this is just an example. Let's say a health minister, maybe even in Cambodia, but this paper was from Africa, has, let's say, for example, $10 per head to spend on healthcare. That is on health economics, okay? And you compare that to approximately 150 million, budget for developed world. So how can these now guidelines, which have been, established in high income countries, be used in low and middle income countries? The money is not the same. The healthcare expenditure is not the same. The healthcare funding is not the same. Okay? So we need to choose wisely. So there's a lot of guidelines that we use from high income countries for low and middle income countries. Yes, some of them are good for guidance, but the real, effects is very different, and the availability of even the recommendations. Yes, so I'm going to talk about 10, just the 10, and harmful practices that really is about the Choosing Wisely campaign. And this, specifically the one for Africa, was led by my colleague Fidel, and they did a study that really summarized their findings in 10 recommendations. Number one, do not order for a test to detect recurrent cancer in patients that don't have symptoms. Dr. Ting was talking about, for example, PSA. It can be falsely elevated in several medical, prostatic conditions, not necessarily only prostate cancer. And if the patient actually doesn't have symptoms, then you'll be wasting money, and patients will be highly selected to do so. Secondly, do not decide on potentially curable cancers without discussing with your colleagues. This is called MDTs, and as most of the colleagues here will know, most cancer cases are discussed in MDT, what we call MDT tumor boards. Okay? So 1 + 1 sometimes is actually more than 3. So if you put your ideas together as a team, you might choose the best for the patient. For example, this is another one. Do not use surgery as an initial treatment without considering neoadjuvant, systemic, and/or radiation. An example of this is breast cancer. If the patient has a tumor on the breast, but at the same time they have lymph nodes on the armpit, or even they have metastasis to the liver, the disease had spread, you don't just go and do surgery on the breast just because the tumor started there. You'll rather give a drug that goes around the body, try to shrink the tumor, and then now, if possible, you do another scan, and then you do the surgery, okay? Or an easier way to explain is don't do surgery in someone who has already widespread disease. What's the point, okay? Do not initiate cancer treatment without defining the extent of the disease. This is CT staging. You know, if someone has cancer, they need to do CT scan first. Let's find out, is this disease only in the breast or it has gone to somewhere else? Do not perform surgery to remove the breast lump without histological confirmation. I think this is also very common. Someone comes with breast cancer, instead of doing a core needle biopsy, first of all, just a small portion, you just remove the whole thing. Maybe it was not even cancer. Maybe it was something else, okay? This is also very important. Don't treat low-risk prostate cancer. There's actually a type of prostate cancer, did you know, that can be treated with active surveillance. You can actually watch and wait. You don't have to treat everyone with prostate cancer. For example, the ones in low grade, the PSA is low, active surveillance should actually be part of the discussion, okay? Do not delay palliative care for serious illness. People believe palliative care is for someone who is dying. No, it's actually should be started from the word go. These days we like calling it primary palliative care, because looks like the word palliative care is synonymous with sadness and just making the patient comfortable. No, it's not that. It's quality of life and should be discussed at the beginning of the diagnosis. Don't use systemic therapy for solid tumors with low performance status, no benefit. So if a patient is really, really sick and they are old and frail and they have a performance status which is like ECOG performance status that is mostly like 3 or 4, there's really no benefit in giving that person highly toxic chemotherapy while you're doing more harm than good, okay? So chemotherapy, patients who are given chemotherapy should be well evaluated and should be assessed for tolerability, okay? Yeah, I think we talked about this. These are some of the guidelines about the chemo. I was just mentioning, do not use combination therapy, multiple drugs, while you can use one drug. Sometimes 1 + 1, less is more sometimes, okay? Yes, and then apart from maybe some exceptions, testicular carcinoma we know is very sensitive to chemotherapy. So if a patient has a high disease burden and you want to treat it with chemotherapy, this testicular tumor has been shown to be more beneficial if you use the combination. For example, BEP, those are 3 drugs than some other tumors which you can actually give 1 drug. So it depends on the type of tumor. Not all of them require more chemotherapy, which is again why we say patients should not be treated without multidisciplinary discussion. The oncologist, the surgeon, the pharmacist, the nurse, the religious leader, for example, people who people who really take part in trying to convince patient in acceptance of the treatment. Targeted therapy. So, these drugs are very expensive. And we like to give the drug if it has the target that it targets. Okay? For example, the biggest and the poster child of targeted therapy is this drug called imatinib. It is a very, very life-saving drug, but if you don't have the target on that tissue, you don't give it to them because it's not Panadol, It's not paracetamol. It's very toxic. As much as it saves life, you have to give the patient the drug if they have that target drug in the pathology report. Another drug that we like giving for chemotherapy is these drugs for nausea and vomiting. Not all patients need. It depends on the type of chemo you're giving or the patient's complaints, So antiemetic, as much as it makes patients very comfortable when they're getting through their chemo, it's not all of them that get. It depends on the drug. Hematology. So this is a paper that I picked from online. ASH is American Society of Hematology, and and it talks about hematological problems in choosing wisely. I'm sure you guys are all clinicians. You see patients who have low HB, and you always see that request form to the lab. Give him 2 pints of 2 pints of packed RBC, red blood cell. Not all of them need. Sometimes one can do, actually. Try to, first of all, address what is the cause of the anemia. Is it iron deficiency anemia? Is it just overbleeding? Find out first. Don't just give everyone packed RBCs. Maybe the patient who need. Those who have iron deficiency, maybe they have malnutrition. Try to correct that, and then maybe you can save that for another person who needs. Choosing wisely. Okay? So this is what I was talking about. They did a study in the UK, and they found that everyone was ordering at least 2 pints of blood transfusion. Not everyone needs 2 units. Biomarkers. I think this was touched by my colleague, Dr. Ting. Prostate. Do not perform PSA testing for prostate cancers in men with no symptoms. Okay, just because you're above 60 doesn't mean I should test you. Do you complain of, having difficulty in urine? Do you have a family history? Did your father or your brother, who is almost the same age as you, die of that? Do you have any issues? Don't test. And if actually you were to test, if someone has a life expectancy less than 10 years from the time you're talking to them, research shows they can actually die of something else than even the prostate cancer. We like joking in the oncology world. We say a 70-year-old will probably die with his prostate cancer than dying from it. He will die with it. Okay. Yeah. So the American Urological Association actually recommends only people who are at the age of 55 to 69. Not only that, those who have positive family history, maybe African American, and those with symptoms. Okay. And this is just some of the tests that they use to check your prognosis if you were to get from the benefit you'll get from screening. I think I've talked about this. Early breast cancer. There is a type of breast cancer which is very early. It's called ductal carcinoma in situ. It means it has only gone to the ducts of the breast, but it has actually not manifested as a growth or as a lump. So those ones, they can actually be treated with just pure surgery. There is actually no need for PET scan, bone scan, and all the CT scans. You save cost, and it will be even choosing wisely. Okay? PET scan is another thing. PET scan is a type of scan we like using in oncology. It scans you from the head to the toe. You can imagine being scanned the whole body. You better be looking for something that you're sure of, okay? And it's not cheap. It's almost what? In Kenya, it costs around $400. That is a lot of money, okay? Yeah, either in some cases like lymphoma and maybe just a small lung nodule that it might help to find out maybe if there is a disease elsewhere in the body, but this has to be really individualized because it's not cheap and it's not easy on the patient. Now, to the most important part of population that can get cancer, the older people, we always like feeling sorry for them. You'll be surprised. There are actually some people, like I just said, an 80-year-old who has a prostate cancer. Just leave him alone. If he has no bone pain, if he has no, urine problems, you don't have to intentionally scan for breast cancer or even for treatment. Sometimes even the treatment can be really very different from the young people because they probably have less expectancy to live for even recurrence of the tumor. Okay, this is another important choosing wisely concept. Clinical trials. We know clinical trials are very important in treatment of diseases, including cancer. So the people, unfortunately, we like using drugs that have been approved through clinical trials in the developed world. Okay, patients are not the same, the population is different, the income bracket is different, the genomics are different, the ethnicity is different. Okay, so there's so many things. So we really need to encourage participation of clinical trials in Africa or even in low and middle income countries so that we can even have actually different drugs for different people. We should choose and select wisely patient trials in Africa, in trials, in clinical trials. And inferiority trials are acceptable. We need to really make sure that the drugs that are being tried on the patients in low and middle income country, they are not bad than the standard of care that we already have, okay? And there should be less toxic drugs to actually try on. Cost effectiveness, I think I've talked about this. If you need to help your patient choose the right test. You as a doctor, actually, don't say, oh, my work is to treat. No, you're a patient advocate. You help them choose wisely, okay? You could say, you know what, after I've looked at you, I feel like you might not have a lot of a problem, but since we found a cancer in your breast, I highly suggest that you just do a scan on this part of the body or that part of the body. That way, it will help them to save cost. It will help them to actually feel informed that whatever they're being told is something that they have shared decision making, okay? So I work also in a rural community cancer center in Kenya, and we struggle with choosing wisely because most patients don't have money for PET scan sometimes. They don't have money for MRI. What do? You assess the patient, their need. So the money, the economic bracket really matters in how a patient is being treated. And that place is called Garissa Cancer Center. It's in Kenya. It's in rural community, but it's actually a big center. That is the map of Kenya. It's in the northeast part, with a population of around 840,000 people. And this center was started 2019. Before that, there was no any center in this part of Kenya. So, Choosing Wisely example. What do I do? What do I usually do in Garissa Cancer Center as a rural area? Why I'm talking about rural is you'll agree with me. That's when really the Choosing Wisely concept actually is important. In the cities, people maybe have money. Probably they even do more tests than they need. But in the rural area, we need to really do what is required and to save cost and to do the right thing. So basically, endoscopy is a must. So that one, we cannot default on that. Radiology, we don't have to do PET scan because it's not even available. So we do CT, chest, abdomen, and pelvis to look for any spread of the disease. And then histology, that is a must. So even though I'm talking about choosing wisely, you cannot diagnose tumor without taking a biopsy. In oncology world, we like saying tumor is a rumor, tissue is the issue, okay? No one should tell you you have tumor, without evidence of histology, okay? And then we don't do a lot of esophagectomy. So in throat cancer or esophageal, my people like calling it throat cancer, so I almost fell for that. Esophageal CA, we like treating it with chemotherapy, radiotherapy, then surgery. But it's a very, very dangerous surgery because they literally have to cut your food pipe. And if there's no one to do it, you shouldn't send patient to anyone because that's not choosing wisely. Treat them with chemo, radiotherapy, and then unless you are referring to a high experienced surgeon in a high volume center, then actually, they could actually live with just chemo and radiotherapy. Is it the right option? It depends on who is asking and who is being treated, okay? PET scan, it's not available, so I rarely ask for a PET scan because CT is available, MRI is available. But in select patients that I feel like maybe PET scan is important, and if they can afford, I send them to other parts. Breast cancer, we biopsy all cases. Again, CT scan, we do that. PET scan, same thing. Histology is a must. Surgery, we have very few breast surgeons, so general surgeons, they end up getting. Okay, and chemotherapy, we use the common, regimen. There are people who talk about conventional radiotherapy and short radiotherapy, as maybe some of you guys are radiation oncologists, but in that center, we still do the conventional radiotherapy. So, finally, we believe that healthcare delivery is transitioning from volume-based, that means doing more, than actually value-based, okay? So there's something called cost is what you pay for, value is what you get, okay? So it doesn't mean you should do so many things, Just it's not volume-based, it's value-based. Choosing wisely, that's actually I will say the real definition of choosing wisely. Emphasis on discussion on the ways to select most cost-effective. Again, talk to your patient. I've told you, you're not only a doctor, you should be a patient advocate, okay? You need to walk them with the journey of diagnosis and treatment. Help them in choosing what actual way they should put their money on. I know people say, oh, it's not my work. It is your work as a healthcare provider, especially in oncology department, in a place that is low and middle income country and a rural setting. So Africa here can represent all low and middle income countries. Infrastructure, health infrastructure is really, really variable. You know, there are people who have money and there are people who don't have money, but they live in the same country, which is actually low and middle income country. So the gap of the income is really heterogeneous. So their care should not be the same, to be honest. Okay. Research to inform choosing wisely principle in oncology, I think, is very important because no one has ever talked about, hey, what is the difference between the rich people when they get cancer and the poor people when they get cancer? I'm talking about cost involved, the treatment compliance, how they are treated, where are they treated, and how long do they survive. I think these are very important research that needs to go into the disparities of cancer care. And with that, I thank you so much. Thank you.